Welcome to lecture for psychopathology. I'll be talking today about psychotic disorders, focusing primarily on schizophrenia. So, starting off with DSM criteria for schizophrenia. Criterion A, which includes the active phase symptoms. Two or more of the following symptoms are present for 1 month or less if treated. So it's just kind of like with mania in bipolar disorder. There's a recognition that there's several drugs that, if given, it'll make these symptoms go away in a fairly short period of time. And the assumption is that you would have kept having the symptoms if they hadn't given you, Thorazine or whatever drug they gave you to stop the active phase symptoms. So active phase symptoms include delusions, which a delusion is an erroneous belief, right, that usually involves misinterpretation of perceptions or experiences. And that part there about usually involves some misinterpretation of perceptions or experiences is important because it's part of what distinguishes delusions from hallucinations. Right? With delusions, usually there's something in reality there that they're seeing, hearing, smelling, whatever, but they're attributing meaning to it that is erroneous. Like if there are crickets chirping outside, and you think the crickets are chirping, to you and telling you words that it's maybe it's Morse code sending you a message. That's a message from God. That would be a delusion, right? Unless, of course, there were no crickets there. If there's no crickets, then that's a hallucination. So delusions, there's something that's really there, but there's you're misinterpreting it, and then there's this kind of a strongly held erroneous belief. Most frequently, delusions are persecutory in nature. The kind of the feeling that someone is out to get you. People are following you. The police, FBI, aliens, whoever. They also might be referential. The idea that things have to do with you that don't, like if it's raining and you think, well, it rains whenever I'm sad. It's because of me. Those things. So this kind of other phenomenon have a reference point where you're the reference point, or somatic delusions. You're feeling that some part of your body is not your own. It's been replaced by somebody else's body parts. Religious delusions, and then also grandiose, which religious and grandiose may go hand in hand if you think you're Jesus. So that might be one of the active phase symptoms, but you don't need any other active phase symptoms. Right? So you need to, unless if your delusions are bizarre, then you don't need any other things. And we'll look. The other things we'll see in a minute are hallucinations, disorganized speech, disorganized behavior, yada yada. You don't need any of that stuff if you have a bizarre delusion. That's sufficient to meet criterion A. So what's a bizarre delusion? It's a bit of a subjective judgment call there. It really depends on culture and the setting, but usually has to do with kind of plausibility. Could it happen? Someone, if you have the belief that someone took your kidneys and replaced them with someone else's kidneys, that's a pretty bizarre belief. If you think the police are watching you, that's not so bizarre. That very well could happen, especially if you're doing some kind of weird stuff. They might be keeping a close eye on you. Okay. But delusions, one symptom. Hallucinations might also be present. And auditory hallucinations are the most common, although hallucinations can occur with any of the sensory modalities. So smelling things that aren't there, seeing things that aren't there, and also feeling things, tactile hallucinations also. Or even gustation, tasting things that aren't there. That's pretty rare. In the movies, it always seems like they're showing visual hallucinations. People see things, and they do that because it looks cool in the movies. But for most people with schizophrenia and other psychotic disorders as well, when they experience hallucinations, they're most frequently auditory hallucinations. And then, kind of like with delusions, there's this kind of special case that, well, you don't need any other active phase symptoms if your hallucinations are a special way. If a certain type of hallucination, well, that's all you need. You meet criteria there. That's if the voice provides running commentary on your behavior. So if it's criticizing what you're doing, usually it's a critical voice talking about what you're doing, or you hear two voices having a conversation with each other. Then you only need this one criteria for criteria. You don't need delusions or anything else. Although you could have other symptoms, you just wouldn't need it for diagnosis. And I think this is where sometimes people start to confuse schizophrenia with dissociative identity disorder, or what used to be referred to as multiple personality disorder. You think about these two voices having a conversation, but it's not. With dissociative identity disorder, that's whenever somebody has the kind of distinct personality states, and it feels like it's some part of themselves. With these hallucinations, these two voices having a conversation, it's usually experienced as not me. Right? It's not me talking to myself. Right? Okay? And you could probably do that to yourself if you're thinking about, oh, what I want to do today. You can talk to yourself, and you can even answer yourself. Not the same thing as a hallucination. Hallucination it's experienced as something other than your inner voice. Right? Disorganized speech is another active phase symptom. Something like derailment. And really, it's not. The phenomenon isn't disorganized speech. It's disorganized thought that's central here, but we can't see the thought, so the symptom is the behavioral manifestation of disorganized thought, which is disorganized speech. Thinking about kind of loose associations. So basically, when people talk and you can't follow, it doesn't make sense. It's not like mania where there's jumping from one topic to the next. There's no thread whatsoever to follow in the logic of what they're saying. There's no organization to their speech. So disorganized speech, grossly disorganized or catatonic behavior, which could include catatonic stupor. So think about generally your behavior is fairly well organized, right? So if you want to walk across the room, you do so, and you're coordinating gross motor, fine motor movements, a lot of different muscle groups, naturally, smoothly, easily. Some individuals with schizophrenia have difficulty coordinating or organizing their behavior, and so they may not be able to move smoothly. They may have kind of repetitive movements where their hands will be going back and forth in a seemingly nonsensical fashion, or writhing tongue movements, which can also be a side effect of some of the treatments, but in general, disorganized behavior. Okay. And then the last part of the active phase symptoms is really kind of different from all the rest. So all these, and then also negative symptoms, which is a whole bunch of symptoms, including things like flat affect, so no display of emotional experience, right? Alogia, which is poverty of speech. Avolition, which is an inability to initiate and persist in goal-directed activities. So not being able to do stuff. So you want to walk across the room and get a can of Coke, and maybe motorically you're able to walk and you could pick up a can of Coke, but you can't get yourself to get up and go do it. You can't initiate. There's something that needs to be done, and people tell you, hey, you need to do this, or you're going to get in trouble, and you don't have the will to do it. That's what avolition means, lack of will, right? Okay, and so kind of because all those things, flat affect, alogia, avolition, are negative symptoms, then hopefully you realize that all the other stuff that are active phase symptoms we call positive symptoms, right? And when we talk about positive and negative symptoms, that comes from the idea that the positive symptoms are whenever there's extra stuff. So like delusion, everybody has beliefs, maybe beliefs that are wrong, but delusion is more of that, right? In hallucinations, we all have sensory experiences that maybe aren't fully, don't correlate 100% with reality, right? You see something and it's not exactly what you think it was, but a hallucination is more. So the positive symptoms are all more of stuff, generally, and the negative symptoms seem to be a lack or a deficit. So not being able to speak, not being able to do stuff, not being able to move, not being able to display emotions. And there do seem to be some differences in general between positive symptoms and negative symptoms, especially in terms of we look at treatment. There's some drugs that will have an effect on the positive symptoms, but not really much of an effect on the negative symptoms. So they seem to maybe have different pathways, different processes involved in bringing about those symptoms. Okay. Criterion B, social or occupational dysfunction. And this really is more than just, with most of the disorders we talk about, impairment in one or more areas, But with schizophrenia, it really seems to be part of the disorder. It's not just that these symptoms. It's not just that you're having problems at work because of the hallucinations. There's something beyond that in terms of social functioning, not able to do it. It's more than just one symptom. It's something else behind that. Probably a combination of things, including lack of certain social skills and some cognitive deficits. Nonetheless, one of the symptoms is social or occupational dysfunction. And then there's a continuous disturbance for 6 months with at least 1 month of active phase symptoms. Right. And we'll talk in a minute about the phases, residual phase, active phase, prodromal phase. So the active phase is when you're actually having at least two of those. You're meeting criterion A. So you're having usually delusions or hallucinations, or maybe the disorganized speech, disorganized behavior, but usually those delusions or hallucinations are present, right? And they're kind of things that catch people's attention. And when you're having those, you have active phase symptoms. But sometimes those symptoms will go away for a while, but not all the symptoms of of schizophrenia will go away. And because they haven't all gone away, you still have a disturbance of presence, and that's why we have the continuous disturbance for 6 months, even though you may not be having full-blown hallucinations, delusions that whole time. You've got some rule-out criteria. It's not schizoaffective disorder or a mood disorder, and we'll talk more about the rule-outs later. The symptoms aren't due to a substance or general medical condition, so it's not just being on mushrooms, and it's not symptoms aren't due to pervasive developmental disorder, unless you have prominent hallucinations. And that the PDD, pervasive developmental disorder, is stuff kind of like autistic disorder. And there's some overlap there when we look at the negative symptoms, especially, and then the disorganized behavior, catatonic behavior. If you look at those two things together, that has some overlap with pervasive developmental disorder. But if it's just those things, if it's just kind of some autistic type stuff and avolition, it's probably PDD, pervasive developmental disorder. But if you're having those hallucinations or delusions, other kind of more classically schizophrenic type symptoms, then you might have both. But that's fairly rare. Okay. So looking at the subtypes of schizophrenia, which it's a question of whether or not these subtypes represent different forms of the same disorder or possibly different disorders, which speaks generally to there's a substantial heterogeneity in the group of people who have been diagnosed with schizophrenia. Right? And they have very different symptom presentations, different onsets, different course of the symptoms, and probably different etiologies. So all the things we're calling schizophrenia, it's probably more than one thing, but we're lumping it all together because we haven't figured out how to divide it up any better. These subtypes are an attempt to divide it up a little better, and I'm trying to figure out, okay, maybe these subtypes represent different disorders, but they're still not sure. Not enough research yet has been conducted, at least it's found consistently that these different subtypes have different etiologies. Okay, the subtypes, catatonic. Somebody has 2 or more catatonic symptoms. So this is when you have motoric immobility, excessive motor activity, extreme negativism or mutism, echolalia or echopraxia. Right? With echolalia is the kind of the nonsensical repeating of someone else's words. So you walk in and say, "Hi, how you doing?" And they say, "How you doing? How you doing? How you doing?" Echopraxia is the same thing, but with movement. Right? So you wave at them and they wave back at you and keep waving, and they're not trying to mock you. Not trying. It's just they see that there's sensory input, and they process it, and it comes out mirroring what you've done. So if you have 2 or more catatonic symptoms, regardless of what your other symptoms are, catatonic. Right? And when we talk about the subtypes, there's kind of this hierarchy where, okay, if you have these things, it's catatonic. Okay, if you don't have 2 catatonic symptoms, then it might be one of these others. But if you have 2 of those, regardless of what other symptoms you have, it's catatonic. So if you don't have 2 catatonic, might be disorganized. Disorganized is when you have prominent disorganized speech, behavior, and flat or inappropriate affect. And flat affect, you probably know what that is. Inappropriate affect is laughing at sad things, crying at funny things, just a mismatch. And then not catatonic, again, because catatonic trumps disorganized. But if it's not either of those, so you don't have 2 catatonic symptoms, you don't have prominent disorganized symptoms, then it might be paranoid subtype, which features a preoccupation with the delusions or auditory hallucinations, which the fact that they name this paranoid subtype can be a little misleading and confusing when thinking about other disorders that involve paranoia, because all you need here is, again, preoccupation with delusion or hallucinations, and you don't meet criteria for catatonic or the disorganized subtypes. Okay. So if you don't meet criteria for any of those, then it's undifferentiated, right? Which simply, you don't meet criteria for any of the other types. You don't have those prominent catatonic symptoms, disorganized symptoms, and there's not a preoccupation with delusions or auditory hallucinations. And then the last subtype is a little different than all the others. Residual, which could be, you could have been any other subtype. A residual is more of like, okay, after you were that, now if you no longer meet criterion A for schizophrenia, it's residual subtype. Okay, and that can involve the presence of either the negative symptoms only with not another. Because if you have negative symptoms and something else, you meet criterion A. But negative symptoms alone doesn't meet criterion A for schizophrenia. Or you could have attenuated positive symptoms. So maybe you had hallucinations and delusions, and now you sort of maybe think you see stuff, and you wonder if the government's following you, but you don't believe it strongly enough for it to meet criteria for a delusion. Right? So it's less strong. That's what attenuated means, right? So attenuated positive symptoms. Okay. So again, those are the subtypes of schizophrenia, which you add to the diagnosis. Which I think the most frequently diagnosed type is undifferentiated, and not surprisingly. Okay. We'll talk about the experience of schizophrenia, onset and prevalence. Typical onset is in the mid-20s, but with a little bit earlier for men than women. So men more early 20s, women later 20s, which makes the average for everybody about 25. Pretty rare disorder. 1% of the population worldwide expected to meet criteria for schizophrenia lifetime. In terms of gender ratio, one of those ones that is equivalent. Right? We often see these discrepancies, but schizophrenia equally likely to be diagnosed in men and women. But it seems that women, some reports suggest that women have fewer and shorter psychotic episodes. So when they're having the active phase symptoms, they don't have them as long and not as bad. It seems to be a more benign course in women than men. In terms of comorbidity, mood symptoms, depression, frequently featured in psychotic disorders, and not clear if that's because of that the psychotic disorder has caused the mood symptoms, or the idea being that having schizophrenia contributes to poor interpersonal relationships, which will then contribute to depressed mood. And that seems to be the case sometimes, but for other individuals, evidence of the mood symptoms are present before psychotic symptoms are noticeable, at least noticeable enough to be diagnosed. So that's still kind of a murky area. Cognitive impairment, and this is cognitive impairment that's not secondary to other symptoms. So this isn't just they're distracted and look like ADHD because they're hallucinating. Individuals with diagnosed with schizophrenia seem to have cognitive impairments that are identifiable before they ever have active phase symptoms, and they also often persist after treatment of the active phase symptoms has been successful. Right? So that suggests there's something different about how these people are able to think, which is probably related to the way their brain is wired and the way it's working. If you think of schizophrenia as a brain disease, one of the core symptoms seems to be some cognitive impairment, not being able to think the same way as other individuals. Related to that probably is social impairment. That people with schizophrenia tend to be more poorly socially adjusted in terms of work, school, romantic relationships, and show deficits in social skills and functioning. They're not as good at reading other people's emotions or picking up on those subtle social cues, which again you can kind of probably hear the overlap there with autistic spectrum disorders there in terms of the not being able to pick up on certain social cues. Right? And again, some of this, the social impairment may be related to the general cognitive deficits that we just talked about. So just not being able to think the same way as other individuals makes it hard to get along in a world where everybody else is kind of neurotypical and thinks generally the same way. So just kind of a side note here, addressing cognitive and social impairments is likely where counselors and therapists will have a chance to work with and help individuals with psychotic disorders. We always think, well, all they can do is medication. And yeah, psychiatrists are heavily involved in their treatment, but therapists can play a role too. And generally, it's addressing these impairments, the cognitive impairments, doing cognitive remediation and social skills training. Right? I mentioned the phases earlier. Which are prodromal, active, and residual. The prodromal phase is when an individual is experiencing not active phase symptoms yet. So they don't meet criteria A for schizophrenia, right? But they have some sub-threshold symptoms prior to the active phase. So again, the course varies. For some people, it's kind of this insidious onset. Some people, it's abrupt. But generally, you go back and somebody's diagnosed with schizophrenia and they ask for, okay, what was this person like before? Usually there's some symptoms that they can look at. Okay, they were kind of a little different in this way. And you can see these prodromal symptoms before the psychotic episode. The active phase symptoms were there. And then the active phase, obviously, is when you meet criterion A for schizophrenia, so delusions, hallucinations, disorganized speech or behavior. And then residual phase is when you have subthreshold symptoms following an active phase. Right. Okay. Looking at the etiology, we talk about biological factors. We talk about genetic influences, obviously, which is a big one, and we know about genetic influence of schizophrenia from twin studies, family studies, adoption studies, linkage studies, which find areas of chromosomes that seem to be associated with increased risk, and the evidence is strong that there is a strong genetic component. The simplest evidence to look at is probably the twin studies. So monozygotic twins, identical twins, if one twin has schizophrenia, about half the time the other twin will also have schizophrenia. Which is probably the highest concordance rate of any of the mental disorders we'll talk about. So schizophrenia has this kind of the strongest evidence of genetic influence. Obviously, it can't be the whole story, otherwise we'd have a 100% concordance rate. But it is a big part of the story, and the degree of relatedness is related to level of risk for schizophrenia. So, someone who's distantly related to you, if they have schizophrenia, there's a lower risk that you have schizophrenia. The more closely related someone to you is, and they have schizophrenia, the greater the odds that you too would have schizophrenia, or some schizophrenic spectrum disorder. Here's the idea that, again, when we talk about schizophrenia, we said it's very heterogeneous, but there are even other phenomenon that we wouldn't classify as schizophrenia per se, that seem to be on the same spectrum, most notably schizotypal personality disorder, possibly schizoid personality disorder, and also delusional disorder, and then schizoaffective disorder. All these things seem to be on this spectrum, kind of like talking about autism spectrum disorders. So this is the same type of thing where there's some sort of brain difference, but it manifests differently in different people. Maybe different parts of the brain that are different. We're not really sure. But the genetic vulnerability seems to be for generally somewhere on the spectrum, not for precise disorder per se. So strong genetic influence, but then also a lot of evidence suggesting that there may be pregnancy and birth complications playing a role, and mostly related to incidents in the second trimester of gestation. We say this because people with schizophrenia have a greater history of birth complications, breech birth, extended labor, but most often these complications involve some loss of oxygen, right? Which loss of oxygen to the fetus causes brain damage, right? But usually not systematic. It's diffuse brain damage, which may explain why schizophrenia is such a heterogeneous phenomenon. And again, the idea here is that not everybody with schizophrenia has a history of birth complications, but a lot of them do. So for some individuals with schizophrenia, birth complications may play a role. For others, it may be other aspects of complications. So maybe a viral infection during pregnancy. One reason we say this is because people with schizophrenia are more likely to have been born in winter months than people without schizophrenia. Right? Maternal nutrition also may play a role. We know that from studies where a group of women were starved, not for science, but for war, and they happened to follow them in their kids and found that these women who were pregnant at the time of the starvation, they're more likely to have children who later developed schizophrenia. So there's several different things that can happen during a pregnancy that might be associated with a greater likelihood of the child developing schizophrenia as an adult, which again is a good while later. But the majority of birth complications don't result in schizophrenia. Right? So maybe these birth complications increase the vulnerability. Maybe some people are more vulnerable to being affected negatively by these birth complications. We don't know, but we know they play some role for at least some people. Okay. And then in terms of neuropathology, so things being different or wrong in the brain. One fairly consistent finding is that enlarged ventricles in the brain for individuals with schizophrenia. And ventricles aren't things, right? They're spaces, really, which, because they're spaces, if they're bigger, the rest of the brain has gotten smaller. So it's kind of an indication of brain atrophy or decline. The brain tissue has died or gotten smaller. And it's one of those things, though, that it's one of the more consistent findings, but not everybody with enlarged ventricles has schizophrenia. Not everybody with schizophrenia has enlarged ventricles. So it's not as simple as, okay, yeah, here's this one thing, but it's a pretty common one. Other things that are pretty common, but again, it's not everybody, smaller structures in the limbic area of temporal lobe. But because no finding is 100% consistent, the conclusion here is that schizophrenia generally is associated with a diffuse pattern of neuropathology. Right? So there tend to be these brain differences in individuals with schizophrenia from people who don't have schizophrenia, but it's not clear yet which differences precede the symptoms and which ones maybe follow the symptoms. So it's not even clear if it definitely is part of etiology or if there's some other disease process that's causing the schizophrenia and then causing these differences that we sometimes find. Beyond that, we look at neurochemistry. So looking at neurotransmitters, and the most prominent hypothesis here would be the dopamine hypothesis, right? Which is just that symptoms are caused by too much dopaminergic activity, and the dopamine hypothesis is based primarily on the finding that dopamine agonists and antagonists affect symptoms that look very much like schizophrenia. So a dopamine agonist like L-Dopa, which you give to people who have Parkinson's disease, it's a precursor of dopamine. You give it to people so that they can make dopamine and increases the dopamine activity, or cocaine, which increases dopamine activity. Give people too much of either one of those, and they develop symptoms that look very much like psychosis. Right? They can have hallucinations and delusions. They become paranoid. It's kind of some of the catatonic behavior. And then dopamine antagonists, if somebody is actively psychotic, you give them a dopamine antagonist, they tend to stop being psychotic. Right? So a lot of the early antipsychotic medications were drugs that blocked the effects of dopamine, or limited the effects of dopamine. But unfortunately, it's not that simple. And one of the problems with it not being that simple is there are different types of dopamine receptors, and these different receptors seem to be differentially involved with schizophrenic symptoms. So we're sort of figuring out which receptors, maybe dopamine receptors, are most involved in symptoms. And when we say symptoms, for dopamine, it's primarily the active phase and positive symptoms. It's like the dopamine antagonists don't do much for the negative symptoms. But then there are also other neurotransmitters that seem to be interacting with dopamine pathways. Things like serotonin, glutamate, GABA, norepinephrine. And we say that, again, not because we are able to watch these chemicals working in the brain, but because drugs that affect these things sometimes work for patients who don't respond to the typical antipsychotics. So we look at those biological factors, and then we can also look at some important social factors. Social class. There's this correlation that low SES is associated with schizophrenia. Okay? And that's correlational, not causational. Two different possible explanations for that are the social causation hypothesis and the social selection hypothesis. The social causation hypothesis is the idea that there is this kind of cause and effect thing, and it's that stressors from a lower class existence trigger the disorder, right? And you can think about stressors being associated with lower SES, poorer access to health care, more exposure to violence, poor nutrition, all these different things that are stressors. So maybe SES causes it. Right? Or social selection hypothesis is the other way around, so thinking basically that schizophrenia causes this downward drift of SES, right? So that wherever people are at in some point in time, if they develop, some person maybe is really wealthy and they develop schizophrenia, they're not going to be able to hold a job, right? And their SES will come down a bit, and then if they have kids, they've passed on a genetic vulnerability to schizophrenia, and they've also passed on a lower SES because they weren't able to hold a job. They couldn't save for college, couldn't provide as much for the kids, so the kid's going to have a slightly lower SES. And then it goes on and on from generation to generation until we get to where we are now. And now we find, okay, people with schizophrenia are overrepresented among low SES, and the idea being that it wasn't always that way, but the disorder caused that downward drift. So either low SES causes the schizophrenia, or schizophrenia causes the low SES. And there's evidence supporting both of these. If we look at male schizophrenic patients, men with diagnosed schizophrenia are less successful than their fathers. Right? Which in America, at least for the past several decades, has not been true for people without schizophrenia. So think about what hypothesis does that support. Men with schizophrenia are less successful than their fathers. So there's that social selection that, okay, if I have schizophrenia, I'm not doing as well as my dad. It must be this kind of downward drift. But we also know that fathers of individuals with schizophrenia are disproportionately from lower class, lower SES, which would be more consistent with social causation hypothesis. Okay, so SES is probably playing some role something that we no longer think is important, but for a long time they did, was this idea of a schizophrenic mother. And the schizophrenic mother you thought of being kind of as cold and distant, or as being probably what we think now of more like a borderline personality disorder, putting the kid in a double bind, where they say, "Oh, come here, kid," and they'd hold out their arms, and the kid would run to them, and as the kid got closer, the mom would wince because she was uncomfortable with intimacy, and that would give this kid this mixed message of "come here, go away," this double bind that they couldn't get out of, and that caused their mind to split. Causes schizophrenia, and no evidence of either one of those things being true in terms of cold, distant mothers or kind of double bind-inducing mothers causing schizophrenia. And lots of people looking for it haven't found it. Doesn't mean that early experiences aren't important. There is plenty of evidence to suggest that experiences of abuse in childhood, especially severe, prolonged abuse, is associated with the adult experience of psychosis, both in schizophrenia and also in other psychotic disorders, including mood disorders with psychotic features. Not uncommon to find individuals reporting that to have had experience of childhood abuse. So early negative experiences seem to potentially play a role. And then another social factor that's received a good bit of support and attention is expressed emotion. Okay, and this is about expressed emotion being kind of a bad thing for relapse. Individuals diagnosed with schizophrenia that get treated. They go in a facility usually, get some meds, get some therapy, and they get sent home. If that home is characterized by being high in expressed emotion, the individual is more likely to relapse. Right? And it's not expressed emotion in terms of talking about your feelings, so it's kind of I think a misleading term. It's really about expressed emotion the way it's been studied, and what we're talking about here is negative expressed emotion that's overly involved emotionally and highly critical, right? So if the person goes home and the family is on their case about not getting up off the couch and not recognizing that, well, okay, that's avolition, it's part of their struggle, they're more likely to relapse. So related to that, whenever families have more understanding attitudes, people are less likely to experience relapse. If the family has more tolerance for their symptoms, they're better off. And what we see, unfortunately, is that people generally are able to tolerate the positive symptoms because they see that, hallucinations, delusions, that's schizophrenia. But the negative symptoms, the not talking, not wanting to be around people, not feeling like doing anything, they don't see that as a symptom. They see that as that person, they're being lazy, they're being a jerk, whatever. So having understanding of family attitudes very important for a positive outcome. Okay, so we've talked about biological factors and social factors in the etiology, but really we don't think about these things in isolation. We think about them working together. So some integration of these things interacting to give rise to the experience of schizophrenia. And by and large, the way people think about etiology of schizophrenia is from the point of view of a diathesis stress model, where people have some vulnerability, some people being more vulnerable than others, but this vulnerability won't be manifested. You won't actually get the disorder, a disorder, somewhere on the spectrum, unless certain stressors are experienced. And what the diathesis is, again, kind of things we talked about, could be genetics, could be sexual complications, could be pathogenic care, kind of abuse type things, or some combination of those things all together might create kind of an early vulnerability, right? Where now this person, because of their genetics, because of what happened when they were in utero or being born, or when they were very young, established this diathesis. And it doesn't seem to be the case that things that happen late in life can create this diathesis, make a vulnerability. And we say that because the age of onset is in the around 25. So it seems to be something that, if there is a vulnerability, it's present early on, either at birth or soon thereafter. Right? And then the stress can be a lot of things. Abuse, abusive relationships, trauma, and then also possibly drugs. It's kind of a biological experience, with most of the research right now focusing on marijuana as possibly contributing to the development of schizophrenia in vulnerable individuals. And there's also this neurodevelopmental model, which is a diathesis stress model put in a developmental context. The idea that there's some early diathesis, some early incident or vulnerability, and whatever happens does its damage to the hippocampus. So there's damage to hippocampal functioning, and because the hippocampus is messed up, now your HPA axis is impaired, which will lead to a greater experience of stress. Right? So even typical things that will cause stress, these individuals will experience more stress, biologically speaking, because of the disruption of the HPA axis, which will then lead to dysregulation of dopamine, and then you go back to the dopamine hypothesis. Okay, if we look at differential diagnosis, kind of get an idea of some other disorders that are similar to schizophrenia, but a little different. Schizophreniform disorder. So the two we'll talk about here are basically the same thing as schizophrenia, the symptom-wise. The only difference is how long you've had the symptoms. So think about PTSD and acute stress disorder. How those are related. That's how schizophrenia is related to schizophreniform and brief psychotic disorder. So schizophreniform disorder is where you meet criterion A of schizophrenia, right, which is 2 active phase symptoms for more than and the disturbance is more than a month, but less than 6 months. Because remember, for schizophrenia, you have to have a month of active phase, and then the whole disturbance has to be for 6 months or more. Schizophreniform, there's no requirement for impaired functioning in the diagnosis. So it's almost like this is okay. You had some stuff going on, but it might be schizophrenia, might not be. You got better, right? Symptoms went away, but for about 2/3 of the individuals, they go on to get some other diagnosis, either schizophrenia, schizoaffective disorder, or some other psychotic disorder, but a third won't. So this kind of goes to show that there are very different courses, and it's not like sometimes it's portrayed where somebody has a psychotic episode where they have hallucinations, delusions, then that's a deteriorating course, and they're going to get worse and worse and end up locked away. No, some people get better. Some people get better and then get worse, but some people get better and stay better. And that's why you have schizophreniform, to capture that experience of, okay, you've had these experiences, and now you're better. And you might not ever have another diagnosis, but most people will have some other diagnosis eventually. Brief psychotic disorder is obviously just briefer than that. So again, criterion A of schizophrenia, more than a day, but less than a month. And this one, it's rare not to go on and get some different diagnosis. If it might be schizophrenia, it might be schizoaffective, might be bipolar disorder. So somebody that comes in they're manic, and they've never had a depressive episode before. It's the first time they're manic. They may get misdiagnosed. People may think, oh, they're psychotic. It really is just some psychotic symptoms in the course of a mood disorder, and they'll figure that out later, and the diagnosis will change. Schizoaffective disorder we've talked about before. So this is when you have 1 month of a mood episode concurrent with schizophrenia's criterion A symptoms, and 2 weeks in the same disturbance with delusions or hallucinations without mood symptoms. So you've got to have the criterion A schizophrenia with mood, and then also without mood, where you're no longer depressed, no longer manic, but still having hallucinations and delusions. So it's really this combination of, it's like a mood disorder and schizophrenia merged together. Which again, in schizophrenia in general, pretty common to have some mood symptoms there. But for schizoaffective, the mood symptoms must be present for a substantial portion of total illness duration. And this is trying to distinguish from those people who have maybe developed schizophrenia and then later developed mood symptoms that seem to be more a result of the interpersonal difficulties they've had related to their psychotic disorder. This is more, you've always had the mood symptoms, maybe even before the psychotic symptoms, during, and still after. So the mood's a big part of it. And the mood disorder with psychotic features, which we've already talked about, it can be major depressive disorder, it can be bipolar disorder. That's when you have psychotic symptoms exclusively during the mood episodes. So when the mood episode's over, no more psychotic symptoms. And then delusional disorder, which is pretty rare. Obviously characterized by delusions, but it has to be non-bizarre delusions. Because again, if you have a bizarre delusion, now you meet criteria A for schizophrenia, so it's schizophrenia. So it has to be a non-bizarre delusion for a month, and you can't meet criterion A for schizophrenia. So it's non-bizarre, and no hallucinations, no disorganized speech, no disorganized behavior, and no negative symptoms. So just this erroneous belief that's held on to very strongly. Okay, well that's it for now. Take care.